All right, Mike, welcome back. Another episode of the 15-minute juice. Um, got another question for you. A lot of this stuff between what we're reading on our Facebook page, and then the ACL Return to Play Club page, the parents of the ACL Club, and then the ACL Recovery Club. We're seeing a lot of questions that are being asked, sometimes like, the same questions over and over again. But something I don't see being directly addressed, maybe, and maybe I'm just missing it, but how do we know when the athlete is progressing the right way? And how do we know when they're ready for that next level of return to play? It gets confusing. It gets a little wishy-washy. Everyone has their opinions on their parents, based off of what they're seeing when they're taking their child to physical therapy. So, but asking you as the physical therapist, in your opinion, how do you know when the athlete is progressing properly?
Yeah, this is a great question, because this really, is going to put pressure on parents. So, I mean, we notice in our facility, when parents come, especially if they're obviously under driving age, the parent has to stay with them, so they're in the facility.
Yep.
Now, there are some parents that'll actually watch what's going on, and it's not even opinion. I think it's a necessity that you're working with, a patient. You should explain, not only to, this is for any patient, what you're doing, why we're doing it, and how it's going to get them better.
Yep.
And a lot of facilities put people on the table and they have them doing a bunch of nonsense. There's facilities where patients have to walk up to the therapist while they're socializing in the corner and ask them, what should I do next? What should I do next? And there's a lot of facilities where they're just going through the motions, or people give them a sheet of paper and say, hey, you do these things, and it's chaos. Now, if you are in a facility where there is a lot of one-on-one attention, that's an opportunity to educate your patient on what you're doing. Again, why we're doing it, how this is going to help you, and expectations for what that movement and position should feel like, and understanding the difference between pain from doing something that's challenging your muscles and your body versus pain that is stress on joints and ligaments and stuff that's telling your body it's not ready for that movement or position. So as you explain that to the athlete, you explain that to the parent. Hopefully the parent is paying attention and watching and looking. There are some parents that come into the facility and, they just kind of trust that the physical therapist knows what they're doing. So they sit there and they're on their phone or they're reading a magazine, but I think that with the amount of money and time spent, I think parents should be a little bit more engaged in watching. I'm not saying hover, but check it out. And if the child doesn't feel comfortable with the parent being there because there's pressure and things like that, or they want to be there because maybe they just feel more comfortable just working one-on-one and having someone, I guess, like watch them,
Yep.
Then the parents maybe stop in like once every couple of weeks to see what's going on, or maybe one session, hang in, ask and see, get a little update, and then drop them off. Because there also is another factor where there is a hovering parent that's pushing the kid and the kid doesn't really want to be doing it. And then when they're not in the facility, you kind of find that out.
Yep.
So a lot of factors that go with that. Well, let's just stick on the principle of the parent wants to get the child better and the child's on the same page, just wants to get better, and they're invested in therapy. How do we know that they're doing the right things? So we look at certain checkpoints of that movement, so we really start with the foundation as to what causes a lot of these movement dysfunctions. And a lot of that starts at the core and the pelvis. And we look for compensatory factors that happen there. So in certain shapes and positions, is the person using their back? Are they extending the back? Are they flexing the back? Are they rotating? Are they losing balance? Are they even tensing up in the neck or the thoracic spine? So as we start building out, I think this little mini series of talking about what the checkpoints of certain positions will be, this is really the foundation. So we really start with looking at how well the athlete can control their spine just on their back, even on their side. We usually don't do quadruped because after a lot of these surgeries, kneeling is tough. Yep. For them for a certain period of time, but eventually we do progress to quadruped positions. And we look at the positions that a human develops as a baby. They start supine, then they start rolling and crawling, and they go to all these positions. So we look at how the spine starts there, because if they can't control their spine and their pelvis on their back, they're not going to be able to translate that into the other positions of standing and other movements. So I really start with evaluating that in those basic patterns, and we get them to work on challenging themselves in those positions with more movements, such as just stable spine, stable legs, and then maybe trying to get them to engage some more of their hip flexors, hip extensors, and look at, the spine can stable, and then we kind of progress them through. So we're looking for those same checkpoints of stability to progress through all the movements. So when a parent says, how do I know if my kid is ready to progress? Well, we literally look at how well can they demonstrate control in that movement. And if they can't control their own body without any other variables in a shape or position, they're not ready to add any other stimulus to that, whether it's, a higher volume or resistance or a non-compliant surface. So we really want to make sure they can demonstrate those checkpoints, body weight first, controlling their own body. Then when they could actually demonstrate, lower reps or sets of that. So I usually start people off at maybe like sets of 10 or 15, good controlled patterns. Then we'll add higher volume. Let's do that a lot. Let's do multiple sets, multiple reps. We even do that with blood flow restriction cuffs on. Blood flow restriction cuffs are, these cuffs that we put on across the inguinal part of the thigh, or also the axilla, to close off the, the brachial or the femoral artery. And it's not full occlusion, it's a mild occlusion. And there's a lot of research showing that the occlusion with the BFR helps to stimulate, muscle hypertrophy gains, cardiovascular improvements. We'll do a separate episode on BFR.
Okay.
But doing that challenges them a little bit more. So we like to add some of those variables of just body weight first and see, can they maintain those checkpoints of positions and stability first, especially as they get tired. And you'll see more often than not, a lot of these athletes, when you start challenging them and just body weight, they start shaking, they start getting tired, they're getting fatigued, they get these little tremors. And all you're doing is asking them to move repetitively in these positions in a clinic with the AC on or the stable surface, no other stimulus. And you can see how challenged they are.
Yep.
And even this is not even just post-op ACL, even some of the kids are bringing for preventative. When you actually dial them back and you don't let them do this survival technique of compensating to move the position and actually get them to target the right muscles, they are significantly challenged.
Yep.
So I think if we start breaking out what people should be looking for, and they understand that, as parents are sitting in and watching their kids go through the movements, they'll know, wait a minute, that doesn't look right, or wow, she's really challenged with that, or wow, she's really can't demonstrate control, or you know what, that looks really aggressive, why are they doing that? It'll start really getting people to understand, am I in the right facility? And does the therapist know what they're doing? Another red flag is if the therapist never explains to you what or why they're doing. Now, once the therapist just comes up and says, yeah, she did good. Again, as a parent, you should ask, well, what did she do good with? And how do you know? And what are you seeing? Why is the knee still swollen? What about this? Ask the questions.
Right. Ask the questions. Right. Right. Yeah. I mean, listen, so, I mean, when they're progressing, so at, like, let's use that example of 9 weeks, and you're having that swelling there, at 9 weeks, yeah, there could be that potential there, and some of that full extension not all there yet. So, but clearly those checkpoints are getting missed if it's getting to 9 weeks, right? You don't typically see that at 9 weeks. When you see that, then is it fair to say that they're missing something in physical therapy?
Yeah, definitely that. I mean, red flags are swelling that is still persisting, a lot, especially after, 8 weeks,
limping.
Yeah, limping, deficient gait, if they're still working on their gait, even if they have full motion. So say, the therapist can push their knee down to the table without any pain, and they can bend the knee fairly well, but then you watch them walk and they still limp. That's a motor control pattern. They're not understanding how to translate the muscles into those shapes and positions, even though they have the full range of motion. The joint and the tissue will go through that range. So there's work there. So you have to start with that foundation of walking before you start adding a lot more advanced things, because otherwise they're going to compensate. There's a reason why they're not, targeting those muscles in that basic pattern. So you definitely want to restore the gait. And then just, simple stability, they should be able to start demonstrating more control, in some of these like split stance positions, single leg patterns. But I really think that it also comes down to severity of injury. If they have just an ACL, they're usually cleared to start weight bearing right away. So a lot of that stuff should be cleaned up earlier. If they have significant meniscus involvement, they're going to be non-weight bearing for a while. So that's going to push it back. That's usually like a 6 to 8 week mark. It depends on how intensive it was, on how much severity of what the surgeon had to try to stitch and repair. So the non-weight bearing is to protect that tissue and to make sure that it's really going to heal. So that might push back a lot of it. So then gait and maybe some of the swelling will be a little bit more delayed because they're not moving it as much. And even though they're doing range of motion or CPM early on and they're doing non-weight bearing stuff, a lot of that swelling gets pushed out by them actually moving and exercising and getting that muscle pump. And then, when they're non-weight bearing and that leg is stuck in a certain position for X amount of hours and they spend certain time doing their exercise throughout the day, it just doesn't counterbalance. So we notice the swelling continues to kind of accumulate in there a little bit. But that's like some residual swelling. It looks just like a little swollen. I'm talking like people that are still going to PT and it's like puffed up, it's aggravated. That's a red flag. It still shouldn't look like that.
Gotcha.
And definitely, that range of motion, if, they're doing activities, but they still have a hard time, like painful getting into full extension and some flexion, and they're doing these advanced activities. It's almost like the therapist like skipped over the range of motion and wants to do the advanced stuff and figures that the knee will just work its way out. That's a red flag. So I think those are some of the earlier progressions you're kind of looking at, making sure a lot of that stuff is cleared up. And then there's other advanced components, like if they have multiple ligament injuries, like if it's an ACL, NMCL or LCL or some traumatic stuff, like you see more of that in some like football lacrosse injuries where there's like arterial damage. We're not seeing a lot of that with some of the high school kids, but maybe some of more of these like contact related injuries, you see some of that stuff. It's a little bit slower. But generally some of the more simple, just ACL tear, a little bit of meniscus involvement, there's some expectations of those progressions.
You talked about forward flexion and the checkpoint there. So what is the tolerated forward flexion that, for those who don't understand that, explain that a little bit better, but then tell me in what degree do you allow them to go to and why not past that point?
So that's the great advancement of having a lot of the technology that we're using, again, like what the Dorsavi system technology analyzes, is when you have the ability to put sensors on someone and watch how they move. And you're somebody like Trent Nestler and a lot of the specialists in our field that are doing the research, you start to try to find, optimization of where the best mechanics are, and now that we have available technology like that, we could start looking at what is optimal, as we haven't had that throughout the years. But also, centuries ago, we didn't really need to do that because we also were a lot more active and physical as a population. So we just kind of balanced out and did stuff that naturally, kept us functional. Whereas now, as we have a lot of things working against us, where we have to try to like optimize our function because we're a lot more sedentary. So now we have to kind of fine tune, well, what does a good squat look like? I know when I'm a small child, my body naturally squats effectively, but now I'm going through all these things throughout life that work against me. I'm sitting, I'm driving, I'm on the phone. So now we get these tissue adaptations and these motor control deficits that work against us. So now we have to find a way to reprogram that. So how do we find that optimization? Because nobody's putting sensors on toddlers to see what the perfect position is. And also, you grow, so your spine and your legs get bigger, and like how do you know what the right angle is? So I think with the research, they've come to find out that no more than 30 degrees flexion at the spine in the squat is optimal. And that's just saying, can you keep your spine at that just 30-degree angle and keep that straight as you squat down? So as you get lower into the hips, can you keep that spine from staying straight? Because then your legs are doing all the work. And a lot of athletes will flex at the spine because they lose, control of their core, and their hips aren't going to work. So they use their back to prevent them from falling on their face, or they hyperextend the back. And some of this you can even visually see. You don't even need sensors. You can see they arch their back way out and they can't get lower. So a simple test is sometimes we put people like their toes are 4 inches from a wall, and we have them put their hands behind their head, and we say squat down as low as you could go. And sometimes when they're in the middle of a floor and they squat down, they get really low, but they compensate. But once you put them 4 inches from a wall, they can't squat any lower because otherwise they're going to smack their nose into the wall, or they physically can't get any lower without arching their back, or they try to move. So that shows them how much control they have. And that's a really simple test to look at. But even dialing it back even more, just simply looking at like a column core bridge, as Bob puts it, if they lie on their back with their knees bent and their feet flat and they lift their butt up off the table, what are they doing to do that? Are they arching their back? Or are they actually keeping their pelvis and spine level and using their legs? Where do they feel that? Do they feel that in their low back? Or do they feel that in their hamstrings?
Right.
So those are simple assessment tools, Same thing when we put them on their side and we had them do a sideline hip raise, which is a common exercise you see. Are they twisted at the low back? Are they rotating? Are they putting their hand on the table to prevent themselves from falling off balance? And is the leg up in the air, is that ankle in line with the knee, the hip, the shoulder, and the ear? Or is it off balance and rotating because they're trying to counterbalance themselves? The same thing will progress into like a quadruped position. If I put them on hands and knees and I tell them to raise their right arm and left leg, do they extend the back and do they lose balance and tip and rotate? Or do they flex the spine and try to compensate? So now you start to see where they're using their spine a lot to compensate. And if they can't clean it up in some of these basic positions, they won't be able to translate that into a split stance, into a lunge, into a single leg pattern, which are all those positions that translate into the foundation for running and plyometrics and agility. So when parents ask, why isn't my child ready for agility and cutting? And it's because these foundational positions are still compensating. They have to get better there first. Once they are stable in those positions and they can demonstrate they could do it with higher volume, higher intensity, other stimuluses, then we could go then we could go and we could progress them into these other variables. You can't just have them work in a closed environment in a facility, like a PT facility or something, where there's no other variables, and just release the floodgates and put them out on a field in front of parents, in front of, other spectators, recruiters, other kids, and all this other stuff. It just doesn't work like that. It has to be those progressions. So to dial it back again, the parents are watching their kids look and they understand where these checkpoints are. And as we build out our algorithm and our program, those are the expectations that we set. So when we evaluate our clients, those are the things we explain. This is what I want you to look like. And in our home exercise program and our online program, we make that very, concise and clear in when we demonstrate in the video. So if someone's at home and they're watching, oh, that's right, I remember those are the things I want to look for in therapy. Right. Here's a review. These are the checkpoints. And if I don't look like that, I'm not doing it right.
Yep. Two examples that we just have recently to kind of go on about the progression here. I have an athlete. Well, she's a former athlete, but I mean, she's still on her feet a lot and she's active. Just had surgery, bilateral meniscus debridement. Okay. She's 2 weeks, 4 days. They have her leg pressing. Now, I don't know how much weight. It could be 10 pounds, but why are we leg pressing at 2 weeks? Would you be doing that with an athlete at 2 weeks?
No way. I just think that a leg press is a very aggressive position, number one. You are on your back and you have weight coming down onto you. So there's a little bit of a survival mode that kicks in. I know they have the stoppers and the guardrails of the weight coming down, but it's natural instinct for people to really push back against that. And they can't control their spine and what they're doing. Even though you're lying and it's supported against something, people can still arch their back or push through their neck and their head and their arms to push that weight away. And again, that's not really, a functional position. I mean, there's a time and place for that. And I think that, you could add in a little bit of some of that isolated strength training, but you want to also translate that power into a functional position, like, regular squats, because that's really going to be functionally. I just think that that's a little bit early, especially if they're still having a lot of swelling and there's a lot of discomfort. There's not a lot of confidence going through there. I just think that there's better options of things they could do before doing the leg press, safely. And again, even just like a simple, the body weight squat, you're able to see if they're compensating. Are they putting enough weight through the leg? How can you measure that on a leg press machine unless you have something that's very high tech and has sensors on it? But then again, I just think that's a little early for 2 weeks. It's just, my opinion on that. But I think the bigger concern, instead of just arguing about or debating about the position, when you want to use it, I think it's just the fact that she has a lot of swelling and discomfort in there still. That would not be my best option of what I would do right away. Okay. I think we have to clear that up first.
Okay. Example number 2, we used this in a past episode, but a girl that ironically, I reached out to the mom and got this information. She happened to send me a video of her doing burpees and kicking a soccer ball and then doing some kind of reaction drill to the wall. I don't know if there was something up on the wall, but the three movements were a burpee for I don't know how many, and then she kicked the ball, and then she ran to the wall to do something. This is 9 weeks. Okay. The mom had explained to me that there was swelling and she was not at full extension. Again, just like I just asked you on the last one, at 9 weeks, would you be doing these type of things with your athlete?
No, this is too aggressive of a movement. This is a multi-dimensional movement, especially, even though it's not a full burpee, it was like a down to the hands and a kick out. There was no chest to deck. But even then, there's plyometrics involved in that. And when you have swelling and there's deficient mobility, now your body's going to compensate to execute that movement. And again, without the full mobility and muscle control, you're going to get stress on structures that shouldn't be taking stress on structures just to complete it. It's a high intensity movement. And then now you are moving quickly coming out of that. So your heart rate's up. So now you're adding fatigue to that as well. When again, there's missing foundational components, you're adding fatigue, you're adding plyometrics, and you're adding neurocognitive, all these things at once. So again, with the kick in the ball, this ballistic movement, and then now you're going up and you're running. This is just a therapist that doesn't know what the hell he's doing. And that's all there is to it. And I'm not going to sugarcoat it. Right. Doesn't know what the hell he's doing. Get out of that facility. And it's unfortunate because the parents think that that's what they're supposed to be done at 9 weeks. So they don't know any better. Yep. But now, hopefully, after listening to this, they'll understand those checkpoints. And immediately, if they see that, they say, what the hell are you doing to my kid? Yep. This is not appropriate. I'm out of here. Yep. So that therapist, I mean, again, this is a doctor of physical therapy. Like, this is why the profession is getting a bad name. This is giving bad name towards sports rehabilitation, because this is what's going on, because people don't know what to do with these injuries. And instead of seeking out and saying this is above my scope or trying to get it, they're just doing stuff to do stuff, and it's dangerous, because what happens if she re-tears her ACL? Or not even that, maybe this is not so much twisting or pivoting. What happens if they re-tear a meniscus or they get some patella tendon flare up? Like, I mean, if that's your child.
It's too soon. It's just too soon to be doing that. I mean, they would be barely combining those three things with me early on. But, example number 3 I want to give, all right, because we talked about 2 weeks, 9 weeks. Let's take someone who is at about 16 or 17 weeks. What are the checkpoints that you're looking for before they would progress to a program like mine, which is a little bit more of that advanced, obviously, that return to play program?
So as we're starting to build out our algorithm, we realize a lot of the loopholes where what's written on these protocols coming from surgeons. And, the surgeons will make these recommendations, week 8 or something, they should be doing, squats or single leg RDLs, but nobody's showing these kids what that looks like and what that feels like. And we know that is dysfunctional at the youth sport and the high school level. There's not enough coaches teaching them how to do that properly. They're learning from either, a senior. So that's a 17, 18-year-old who thinks he knows what he's doing. And where did he learn that from? So there's this trickle down of lack of information. So we're just assuming that these kids know what that looks like. And we're assuming also, or expecting that the physical therapist knows how to teach them those things. And we're seeing that's not being done. So as we start to clean that up, we're saying, well, how can we make this better? And what is a good squat, a good RDL? So, as we break down these movements and look for the checkpoints, we are looking for, if we are giving these kids the proper dosing of program and progressions, and we're cycling through 2-3 times a week of them going through practicing these techniques, and they're doing their stuff at home, we are expecting that by the time we do the first sensor testing with the Dorsa V at 16 weeks, they at least have a good baseline of core control for the plank, and the side plank. So that means no extension at the lumbar, no flexion, and there's good control. Same thing with a side plank, that they have a stable spine, and if you get the hip off the floor, the bottom leg in the side plank is not touching the floor, that they can actually push out through the ankle. So they're getting perineal activation, which is the muscles that move your foot outwards. So there's space between that bottom leg and the floor, and they're not just resting that bottom leg on the floor. And obviously the ability to complete the planks for 60 seconds. The other movement we look at too, obviously, is a squat. Can they at least get down to at least 90 degrees with good core control? So no flexion more than 30 degrees, no hyperextension at the back. And then, no valgus at the knees, so the knees are not collapsing in, the feet are not collapsing in, there's no weight shifting from side to side, so that lateral shifting is minimal. And then, a single leg RDL pattern, when they do a single leg squat, is that spine controlled? Are they actually getting into the hip? Are they flexing over the knee and the ankle? Or is it like a real shallow, like a little baby squat?
Yep.
Or are they doing it and losing balance? Or are they corkscrewing where the leg behind them is like pivoting and it's like fishtailing and rotating them? And then the same thing, we don't really expect much plyometric output at that 16-week mark because there's so much work done on that foundation that, again, if they're single leg RDL, we know that takes some time for them to build up. That if they could jump and land on one leg, obviously with good control and without losing balance, but we start to see that develop a little bit after that. So probably around that 5-month mark, we start kind of introducing some of that and expect to see some improvements by the next testing. But and definitely the multi-directional hopping, we don't expect much of that, but we like to get a baseline on it just to show why they can't do certain things, why they're not ready for agility, why they're not ready for running, and then some of the movements that aren't tested with the Dorsa V, we just like to look for obviously good alignment and control in the hip, knee, and foot with a lunge pattern, a split stance pattern. Can they at least stand on one leg for 10 seconds on a stable surface with the eyes open? We like to progress that to eyes closed without loss of balance. And then obviously a hip hinge pattern, double leg. Can they demonstrate a double leg hip hinge, like a deadlift with good posterior weight shift? Can they put their butt behind them? We're keeping a spine stable and coming up and down. So those are kind of really the base, a lot of the functional movements that we look at and want to make sure that they have a good foundation of those checkpoints, and can they do, multiple sets and reps of those movements without deficits and probably with some introduction of resistance. Right. So a lightweight or a non-compliant surface with some fatigue, like the BFR, before they at least start thinking about entering into your program, because that's where you really take that foundation that we laid down. It's like a base layer of cement. Yep. You need that base layer of cement to be laid down, to be dried and stable before you start building off of it. Yep. And if it's still slipping and it's not dry yet, everything else is going to come tumbling down. That's where a lot of parents and athletes and coaches want to push these kids. That base layer of cement is not solidified yet, and they want to build off of it, and they just build this house that is continuing to teeter and shake, and they don't understand why.
Talking about building a house on sand. I like that one. Yep.
Yeah, you're basically building a house on quicksand for some of these kids.
Right. Yeah. For sure. But listen, I think that really gives us, and not just us, but everyone listening, the parents and everybody, that just gave them 3 different examples. At 2 weeks, what you should and shouldn't be doing. At 9 weeks, what we've seen and what is appropriate. And then at that 16, 17 week mark, when they should traditionally start to be moving into that advanced type of program where they can get into doing more plyos and landings and things like that. So I think that this should help educate the parents a little bit better, a lot better on where the progression goes. So once again, another great episode. Sure, we're going to have tons of other questions. So I'll be seeing you soon.
Yeah, and again, I hope that this just continues to just open their eyes up, because there's a lot more elaborate, things that we'll elaborate on, and build off of on these things. But this just kind of gets them to start thinking about what we're talking about and get the wheels turning.
Yep.
And then we'll start to build off of this with follow-up episodes of getting a little more specific. But this just kind of gets people to open up their eyes. So to some expectations of what they're looking at.
Yep. And speaking of the wheels turning, in my head, in the back of my mind, I'm going, we definitely need another episode with Trent. I know he's busy, but if we can pick his brain, especially about the new version of what they got going out on with the Dorsa V. I know he's talked with Maka and some of the other, physical therapists. So I think that, maybe reaching out to him, and if we both text him, maybe he'll jump on and we can grab him for a 30-minute call or something. Yeah. I think that would be super valuable as well. But again, another great episode. Appreciate your time.
Absolutely. Talk to you soon.
Later.
All right.